So, very good evening, one and all. Very good evening, fellow doctors. Very good evening, ladies and gentlemen. So, thank you all for joining in at this time for an academic feast that is to follow, uh, with special objectives of updates from the HFA scientific sessions. As we all know, the Indian scenario of heart failure, it seems quite grim. The estimated prevalence in India in various studies being between 1.3 to 4.6 million, with an average of 1.8 million hospitalizations annually in the country. It is among the leading causes of hospital admissions in the elderly population. And a key point to note is that the Indian population actually manifests with heart failure admissions at a much younger age, an average age of 53, compared to our Caucasian brethren who arrive in the hospital at an average age of 70. Also, the in-hospital mortality rate in India is high, with various studies showing between 10 right up to 30%, versus in the Western countries where it is just somewhere between 4 to 7% documented in various studies. So, are we doing right with our patients, or do we need to stay abreast with more modern therapies? Or do we need to enhance our practice? To understand perspectives on the same, we have some of the brightest minds to educate us for the day. And I have the honor of introducing our esteemed moderator, Professor PC Manoria, and Dr. Giuseppe Rosano. Coming to Professor PC Manoria, sir is the director of Manoria Heart and Critical Care Hospital, Bhopal, the former professor and head of the Department of Cardiology at Government Medical College, Bhopal, and honorary physician to the Governor of MP. He's been the past national president of various bodies, including the CSI, API, and the ICC, the past chairman of the Hypertension Council, the Asia Pacific Society of Cardiology, and the past vice president of the SARC Cardiac Society. He's been awarded with various awards and various accolades during his entire academic career. He has organized several national as well as international conferences over the last 40 years and has also organized the World Congress for Cardiometabolic Medicine in 2019 and in 2022, respectively, has edited 33 books and has 74 publications in various peer-reviewed journals to his credit, and as we all know, has delivered more than 800 lectures in various national as well as international conferences. Next. We also have the astute honor of inviting Dr. Giuseppe Rosano, who is the president of the Heart Failure Association at the ESC. Sir is a professor of cardiology at St. George University Medical School, London, and is also a director in heart failure and therapies for the same. So, Professor Rosano received his medical degree and his specialization in cardiovascular medicine from La Sapienza University of Rome in Italy and his PhD in medical sciences from the Imperial College of Science and Technology in London. Professor Rosano has also served as a member of the CVWP of the EMA since July 2020 and has been a board member of the Italian Space Agency and member of Pricing and Reimbursement Committee for the Italian Drug Agency. Sir is also a fellow of the European Society of Cardiology, the Heart Failure Association, the ACC, and the Italian Federation of Cardiology. He serves as an editorial board member for various journals of the EHJ, and also further journals like Cardiovascular Diabetology, Nature Research, Scientific Reports, Cardiovascular Reviews, Advances in Therapy, European Cardiology Review, and Climacteric. Professor Rosano has authored more than 500 peer-reviewed articles and has them to his credit in various national as well as international journals. And as we all know, he is the honorable president of the Heart Failure Association at the ESC. On the same note, I hand over the session to Professor Manoria. Sir, over to you.
Good evening, everybody. It's my great pleasure to share this program with Professor Dr. Rosano, of whom I am a great fan, and he has come in our second World Congress in Cardiometabolic Medicine, Mumbai. So medical science is a rapidly advancing field where yesterday's fact may become matter for the archives to store, and today's fact may not find agreement with experts of tomorrow. Continuing medical education is therefore an integral part of medical profession. All of us know heart failure is a deadly disease with a very high mortality. The 5-year mortality may be the tune of 50%, a figure higher than most of the malignant lesions. But the last couple of years has witnessed a sea change in heart failure, both in terms of enhanced understanding and in the availability of a panoply of new therapeutic options. The four foundational drugs for heart failure, beta blockers, SGLT2 inhibitors, RNA and MRAs, all of which are available in India, have kicked off a of new era of revolution in heart failure which was never heard before, and this is a big step in improving the outcome of heart failure. For worsening heart failure, we have Verisuget. Sotagliflozin is not available in India, and omecamtiv mecarbil is still in the process of development. But what is very, very distressing is that the Indian context, where we are having 8 to 10 million patients of heart failure, 22.5% patients of heart failure are below the age of 30 years. The incidence of diabetes in heart failure is 54.5%. Post-admission mortality is to the tune of 20 to 30%, and medication adherence is 25 to 50%. In the recently concluded ESC Heart Failure Association meeting at Prague, several breaking trials were presented, like removal of amyloid in the ATTR amyloidosis by intravenous antibody, the Paraglide HF trial with RNA, and the pooled analysis of Paragon and the Paraglide HF trial, the Monitor trial, the adverse effects of misuse of loop diuretics, the ENACT trial, and the FINACT trials with finerenone in heart failure with mildly reduced ejection. Dr. Rosano has a masterly approach of solely unmasking the depth of the problem. The clarity of expression leaves behind an everlasting imprint in the minds of the audience, and I'm sure all of us will enjoy the flashes of expertise during the discourse of Dr. Rosano. So over to Dr. Rosano for presenting the highlights of the HFA 2023, LBCTs, and the guideline. Dr. Rosano, please.
Professor Manoria, first of all, thank you very much for your introduction. It's always a pleasure meeting you, and we share many good experience together. Now, it's been really a pleasure to open and close the HFA Congress 2023. When we opened, we were not, we had good expectations, but then, as you will see, many trials have been presented, but also together with the trials, we've presented updates on what will be in the guidelines. So we'll see and start, and I will do a rapid presentation of the most important trials, and I will end with the two scientific papers and the position papers of the HFA that basically highlight the importance of some diagnostic and therapeutic pathways. Now, the first trial I will be present is the importance of the strong HF in elderly patients. Now, do you know that strong HF was a trial where there was a fast up titration guided by BNP in patients with heart failure, was stopped early because of a clear benefit of aggressive therapy. So, but that is something that we cannot be implemented everywhere because it was, say, a 2-week follow-up that not everywhere is feasible. Now, as you can see, there was no difference. When they looked at the data by the age, they found that there was no difference in patients with the age greater than 65 or less than 65 to achieve the high dosage that was achieved in 80% of patients. That is more than 50% of the average dose of each medication. And whilst in the standard care group, as you can see, where you see that the visits were after 3 months and 6 months, the up titration was much, much less. Now, as you can see in the overall cohort, and there was a benefit, especially in those below the age of 60. Whilst in above the age of 60, the benefit of a full uptitration and rapid uptitration were not clearly seen. But one important point is what a rapid titration does on quality of life. And as you can see here, the high intensity care was induced a significant improvement in quality of life in young patients, but much less in older patients. Also, a high proportion of patients that were randomized by intensity care had adverse events, including hypotension, kidney injury, hyperkalemia, and so there was the issue of whether we should be so aggressive in patients with, in elderly patients with heart failure is still open, and also but however, the serious adverse events were similar between the two groups. So the STRONG-HF highlights the importance, especially in patients below the age of 60, to fully implement and rapidly implement the medical therapy. It is this advantage probably is much less evident in patients with above the age of 35. Another important trial that is because it highlights that despite the big clinical trials demonstrated a clear benefit of the four foundation therapy. Now, and we thought that given the benefit of and the established benefit of all these medications, it would have been difficult to come up with new pathways that may improve mortality and morbidity. But as you can see, the trientine was tested in patients with heart failure reduced ejection fraction, and that was a phase 2 trial. Now, the background of this and what is the trientine? The background, first of all, is that in the intracellular copper depletion is associated with hypertrophy and fibrosis and the risk of remodeling. So the restoration of intracellular copper, especially in animal model, was reverses the left ventricular hypertrophy. Trientine is an oral copper chelator that acts as a copper chaperone at low dose. So basically transfers the copper into the cells and has a very significant effect on myocardial function. The study presented at the HFA was the TRACER-HF study, was at phase 2A, that was assessing the effect of multiple doses of trientine in patients with heart failure. Now, they were all patients with heart failure reduced ejection fraction, and the addition of trientine was very well tolerated up to a dose of 300 milligrams and was associated with a significant reduction in NT-proBNP at 4 at 8 weeks. But what is important is that a post-hoc interaction showed that is significant, even greater benefit in those patients with a left ventricular function less than 30% at baseline. This effect were maintained and were sustained as 6 months, and this will open the doors for a phase 3 clinical trial. Then, of course, we know very well the beneficial effect of dapagliflozin in patients with heart failure, with both reduced and preserved. And this study looks specifically at the combination of DAPA-HF and the liver, so the two trials conducted with dapagliflozin in patients with reduced and preserved ejection fraction on the health status and quality of life. And as you can see, if you look at the total symptom score, there was a clear benefit. This is no effect. This is a clear effect, beneficial effect of dapagliflozin across the left ventricular function, going from patients with very low ejection fraction to those with very high ejection fraction. This also was associated with a significant increase in the clinical summary score, also the overall summary score, and the benefit on physical limitation. So basically, dapagliflozin demonstrated that the effect is completely independent of left ventricular function that improves symptoms, the clinical well-being, and reduces physical limitation. And you can see that in the vast majority of patients, there was a very significant benefit, and you need to treat very few patients in order to have this benefit. Now, another important trial was the Transform HF. The Transform HF was a study that compared torazamide versus furosemide on all-cause mortality, but also looked at the quality of life and symptoms of depression. It was a study conducted mostly in the US. And as you can see, there was basically a similar effect of furosemide and torazamide on well-being, on KCCQ, so a score of quality of life, in patients with heart failure and reduced ejection fraction. So the effect is absolutely similar. And you can see that there was a significant and immediate change and benefit of diuretic therapy. Now, you may know that the Ironman, that was a study that used IV iron. In this case, was the ferric derisomaltose that was used in patients with heart failure and reduced ejection fraction. They were randomized to receive ferric derisomaltose or control. And the study demonstrated, like all the other studies with ferric carboxymaltose, a significant reduction in the endpoint of mortality and hospitalizations for heart failure. Now, what is important is that in this analysis at the HFA was presented the analysis based on age groups, and you can clearly see that in the elderly patients there was a benefit across all the different age groups, but there was a very significant effect in those patients who had more than 79 years of age. So basically, the Ironman enrolled mostly older patients with heart failure and reduced ejection fraction. The older patients were symptomatic, had a worse renal function, a lower hemoglobin, and in these patients, the IV iron was effective in the no attenuation of effect and increased hemoglobin. As we've heard from Professor Manoria at the beginning, there were trials that were presented at the HFA that looked more specifically at ATTR amyloidosis. One of these was patisiran treatment with cardiac amyloidosis, and was presented by Dr. Beck. And you know that the patisiran is an interferon RNA therapy that is approved for the treatment of ATTR amyloidosis with polyneuropathy. The Apollo B was a phase 3 randomized trial that looked at to evaluate the efficacy and safety of patisiran. This was conducted over a period of 12 months, and they evaluated 6-minute walking test, KCCQ, and biomarkers, but also the composite clinical outcomes and death over 18 months. As you can see, the patisiran was very effective in maintaining the physical functioning, the KCCQ, and also in keeping the NT-proBNP low. While as you can see, those patients were randomized to placebo at a progressive deterioration. So basically, what happens is that in patients with amyloidosis, once they're diagnosed, they continue to progress and worsen. If you give patisiran, that freezes their disease and leads to a stabilization of the clinical profile. What is important also, there was a tendency towards a significant reduction of all-cause mortality and hospitalization. And if you look at the effect of all-cause mortality, that was had a significant trend towards a 50% reduction in mortality. Professor Manoria hinted at the Paraglide HF that looked at patients with sacubitril valsartan in worsening heart failure, especially in patients with reduced or preserved ejection fraction. The study randomized 466 patients either to sacubitril valsartan or valsartan and looked at the worsening heart failure. And if you look at the primary endpoint was the change in NT-proBNP, but also in a hierarchical endpoint, so cardiovascular death, atmospheric hospitalization, cumulative number of hospitalizations, and safety outcomes. You can see here the results. There was a significant effect of sacubitril valsartan in reducing the NT-proBNP. But what is important is that looking at the clinical outcome, there was a significant overall benefit of sacubitril valsartan, and using what is now trendy, so is the win-win ratio. So what is the win-win ratio? Basically, and it's very simple, is that just the opposite of the relative risk reduction. So if you have a win-win ratio of 1.19, it means that there is a 20% greater benefit with the therapy. And so there was a 20% greater efficacy of the treatment with sacubitril valsartan in these patients with mildly reduced and preserved ejection fraction. So this supports and strengthens the benefit of sacubitril valsartan in patients with left ventricular greater than 40% up to 55%. Now, we know that pulmonary artery monitoring is effective in patients with heart failure. However, we lacked a trial, a definitive trial with good numbers. And the Monitor HF study was a randomized clinical trial that was presented at the HFA and published simultaneously in The Lancet. So basically is the highest ranked journal worldwide. So you can see that the Monitor HF was a multi-center study and included 348 patients randomized to standard of care compared to PA-guided therapy. You know that what was tested was the pressure device that was inserted in the descending branch of the left pulmonary artery. That is the cardiomems, and that senses changes in blood pressure. What the patient do is that they lie on this sort of mattress and transfer all the pulmonary artery pressures. And if there's an increase in pulmonary artery pressure, there is an indication for the use of increased diuretics. The Monitor HF trial clearly demonstrated a very significant and sustained difference with the use of pulmonary artery pressure monitoring. You can see that there was a significant improvement in guideline-directed medical therapy, and patients were receiving the pulmonary artery monitoring, the cardiomems, and a significantly lower risk of hospitalizations. Another important trial that was presented in the same session was this phase 1 trial of an antibody, NI-006, for the depletion of cardiac TTR amyloid. You can see clearly, I think that there's no need to show statistics for this trial if you look at the images. You see, these were the images of patients at rest before starting the trial, a clear accumulation of the tracer in the heart This was at 4 months, and this was at 12 months, where the tracer almost disappeared. So that was it was so significant that the study was published simultaneously in the New England Journal of Medicine, and also they looked at with the MRI, they looked at the presence of the extracellular volume, that is an index of inflammation, and you can see that over 12 months that improved, suggesting a very important effect. So in the depletion of amyloid, but also reduction of inflammation. Now, if we switch to acute heart failure now, there was a study that was the ENACT HF, where patients were had an optimization of diuretic therapy according to the use of sport sodium, urine sodium. And that was to support the European guidelines that in patients with acute heart failure suggest that we need to use the spot urinary sodium in order to increase or decrease our diuretic therapy. You can see that in patients with underwent the spot sodium analysis and guided therapy according to the spot sodium assessment, there was a significantly greater natriuresis, a significantly greater diuresis, therefore suggesting that this is what we should do in the acute patients, especially when we have doubts about diuretic resistance. So we need to be guided on the therapy, on the dosage of our diuretics according to the urinary sodium. On the same line, there was a chlorotic study. There was a study that looked at the combining a thiazide diuretic with furosemide. And as you can see, the doses of hydrochlorothiazide were stratified according to the level of EGFR. And the efficacy endpoint was weight loss. And in those patients with, there was a very significant receiving hydrochlorothiazide, in addition to intravenous furosemide, improved the diuretic response in all patients with acute heart failure, regardless of the initial EGFR. And however, this effect was higher in those patients with a better baseline renal function, but this is something that we would expect anyway. Another very important point is the initiation of MRAs. And the combination of MRAs and diuretics is very important. And this study looked at the MRA initiation during admission, that is, and demonstrated that it associated with improved outcome. Now, we know that there is strong evidence from the guideline to recommend MRAs. There is a perceived risk of renal insufficiency that has never been proved. And this study looked at more specifically at the effect of adding an MRA compared to those who continued or had no MRA or discontinued. You can see that those patients who discontinue an MRA have a significantly greater mortality. Those who have no MRA at all have also a higher mortality, whilst those patients who start an MRA together with the diuretics had a significant reduction in mortality and morbidity. Going back and continuing into patients with heart failure, there was the study of a PULSE study. There was a study with empagliflozin that looked at the effect of empagliflozin in patients with acute heart failure. The study demonstrated a significant benefit of SGLT2 inhibition in patients with acute heart failure, thereby suggesting that it should be used and continued. Now, what was not clear was the effect across the left ventricular function. You can see here that the results were absolutely the same across the left ventricular function. So if you start an SGLT2 inhibitor, then in patients with reduced, mildly reduced or preserved ejection fraction, you get absolutely the same benefit. And this is even more clear here. You see there was no difference about the benefit of the SGLT2 inhibitors in acute heart failure in patients with reduced, mildly reduced, and preserved ejection fraction. That was observed on the win-win ratio, was observed on all the different endpoints. Regarding the SGLT2 inhibitors, we until recently we had no clear evidence of the benefit of SGLT2 inhibitors on cardiac volumes. The DAPA moda was a singular was a multi-center interventional studies that looked at the effect of dapagliflozin on cardiac remodeling, and as you can see, there was an effect of dapagliflozin in significantly reducing the left atrial volume and improving left ventricular volumes compared to placebo. And that was similar in patients with reduced and preserved ejection fraction. You can see more clearly here that there was a significant improvement in left atrial volume reservoir. There was a highly significant in all patients, and also a significant effect on left ventricular remodeling. Going toward the end, with there was what is important in acute heart failure is the assessment of congestion. This study looked at the combined effect of looking at congestion or looking at the B lines on the pulmonary arteries, looking at the pulsatile venous pressure in the kidney, and the IVC. They look at this protocol that takes less than 3 minutes between and with a mean of 5 minutes in the difficult patients, and they came up with a score that is the congestion score. So if there's more than 2 signs of congestion, that means that patient is really congested. And as you can see here, they clearly demonstrated that the more the congested is the patient, the worse is the mortality. So basically they suggested a multimodality assessment for congestion that together with the clinical assessment, also the assessment of congestion of the pulmonary congestion, kidney congestion, and liver congestion is associated with worse prognosis. Now, going to the end, I just want to show you the two important position papers that basically set the stage for the treatment of patients with heart failure. The first one that we presented was the one on the new definition of worsening heart failure. And the definition of worsening heart failure has been sort of unclear until today. Now, what we did was we've expanded the definition of worsening heart failure. That is not the presence only of hospitalization of ED visits, but also includes the worsening of signs and symptoms, the presence of congestion, and a decrease in exercise capacity. So that is very important because that extends the worsening definition to many patients. But also we can assess this subclinical worsening with biomarkers, imaging, and pulmonary artery pressure monitoring. As we said, and you've seen the data from Transform that I presented earlier, that basically demonstrate that the use of pulmonary artery monitoring is associated with a significant improvement in function. Also, what we've suggested and what we suggest as a modern treatment for patients with worsening is that together the 4 foundation therapies with RNA beta blockers, MRAs, and dapagliflozin, or if you want empagliflozin, then there is a need in patients with a left ventricular function less than 50 for the use of intravenous iron, but also, and this is important, as highlighted earlier, the importance of the use of the SGC activators. We have only one, that is vericiguat, and therefore now today there is a clear recommendation from the heart failure to use the vericiguat in patients with worsening heart failure. The last point I want to focus is the need for phenotyping patients with a left ventricular function greater than 40%. And as you can see, there is evidence that with patients with heart failure and preserved ejection fraction or mildly reduced ejection fraction have a high incidence of arterial hypertension, coronary artery disease, elderly or atrial fibrillation, and across together with all sorts of other comorbidities. So what we suggested is that based on that, we need to phenotype patients, and when we find patients with a left ventricular ejection fraction greater than 40, first step is to start dapagliflozin or empagliflozin, plus or minus a diuretic if there's congestion. Then we need to phenotype, looking at the different comorbidities. We have some comorbidities where there is a clear indication for specific treatments. And then, according to that, we need to suggest all those therapies that are effective, like in patients with hypertension, ACE inhibitors, BORNI, indapamide, nebivolol, or and the MRAs. That is a very important issue because together with diuretics, we need to use possibly in combination the diuretics and MRAs. And whilst for patients who are obese, there is a clear indication for use of semaglutide or tirzepatide on top of dapagliflozin or empagliflozin. The same in patients with type 2 diabetes. And in patients with iron deficiency, the use of IV iron. Then we can modulate our therapies according to the presence of COPD when there is an indication for LAMA-LABA and beta blockers, and in patients with ischemic heart disease where there is a need for anti-ischemic therapy. So at the end, the HFA Congress was a big success. We had 4 days of science and updates, 4 late-breaking sessions, then simultaneous publications in the Lancet, New England Journal of Medicine, European Journal of Heart Failure, and JACC Heart Failure, and 2 new position papers that set the clinical need for an update in the guidelines, and you will see that reflected in the guidelines very soon.
Thank you, Dr. Rosano, for the wonderful talk, which was packed with current scientific information on heart failure. So the first issue in the Indian context is suboptimal GDMT and poor adherence to therapy is a very important cause of increased morbidity and mortality in the Indian context. So what are your suggestions to improve both these things?
That depends. First of all, it depends on the different settings. I mean, India is a huge country, and therefore you have different organizations in different regions and cities. And if you have structures where you can have a close monitoring of patients, you can see patients at 2 weeks, 4 weeks regularly, then the up-titration, the fast up-titration works, especially in those with less than 60 years of age. Otherwise, as we have recently shown, it is better to use all the 4 foundation therapies at low dose rather than trying to up-titrate other medications. What is important is also that the fixed dose combinations are also very effective because they reduce the pill burden and therefore they will increase adherence.
One of the difficult scenario which we are facing these days is a patient of HFrEF, ejection fraction was less than 35. He was prescribed ICD, he got it implanted. After a few years, ejection fraction has now increased to 40, 42. Now the time for battery change has come and we are in a dilemma whether he should change the battery or we should stop ICD because his ejection fraction is now 42. He is now ineligible for ICD. So what's your expert opinion on this?
In all studies, what was important, it was the left ventricular function when that patient was treated. And since it was less than 35%, then there is an indication to continue with the therapy with the ICD. I don't know whether that was just ICD or CRT plus CRTD. And therefore, I'm always, we don't have a clear guidance. We don't have clear data. If that left ventricular function was not ischemic in origin, or was a dilated cardiomyopathy, then probably we have little evidence to continue. But for all other cases where we have a clear cause, then I would rather continue and just change the battery.
In your opinion, what will be the impact of the current GDMT on the device therapy? How long they will postpone? What will be the impact on postponing device therapy, CRT, LVAD, even cardiac transplantation?
Look, again, it's we need to have at least a 40-45 days for patients with in ischemic origin, and so it's that is goes without saying. For all the others, if we can wait up to 3 months, that will be even better, because we see the effect on remodeling when you start guideline-directed medical therapy.
A patient of HFrEF on GDMT has improved substantially, his ejection fraction has improved, he has now very little symptoms. How long the GDMT should be continued? Indefinitely, or what is your opinion?
Clearly, indefinitely. Because we have data from the TREDHF that if you stop the guideline-directed medical therapy, patients will get worse.
All of us know SGLT2 can be used across the spectrum of heart failure, irrespective of the ejection trial. All trials have shown this. The issue is patients with amyloid heart disease were excluded. So is there any data available on the use of SGLT2 inhibitor in this subset of patients?
I mean, they've excluded patients where there was a clear diagnosis of amyloid, but most probably in those groups of above 65%, there was a group that had amyloidosis, but that amyloidosis was not diagnosed. And especially with dapagliflozin, there is a clear evidence for a benefit in patients with higher left ventricular function. So I would say that if there are signs of heart failure, I would use the dapagliflozin regardless.
How do you look at the prospects of this antibody treatment for amyloidosis compared to tafamidis, which is already approved in times to come?
I think tafamidis is effective, and as I showed you, there were trials that clearly showed that patients stabilize with tafamidis. But with the antibodies, there is a clear reversal of the disease. So this is really a game changer. Now, of course, we need to see the real clinical effects, and I showed you the data on our patients are much better, and but we need to for sure start patients on tafamidis. When we will have the new therapies, then we need to switch to the new therapies.
One of the common questions which is asked by the physician is, how do you select between DAPA and EMPA? Both have been approved for treatment of heart failure.
I think it's preference. With dapagliflozin, we have a clear evidence of clear efficacy all across the board. That is very, very significant. Also, we have data from the DAPA-CKD that have confirmed the benefit. There is not just on cardiovascular endpoints, but also on the overall mortality, not just cardiovascular mortality, but total mortality. So we have DAPA-HF, the DAPA-CKD that clearly support the benefit of dapagliflozin. It's I think we are where we were with the statins. I mean, we started with Simva and Prava, then we had Atorva. Then if you have to choose for a patient at high risk, what would you use?
The other issue which we
you would use probably DAPA.
The other issue which we face is patient of heart failure is on SGLT2 inhibitors, he develops acute myocardial infarction. Will you continue with SGLT2 inhibitors, stop, or what is your strategy?
No, you continue. I mean, there's a clear, of course, patients in the trials, they have events in any case. So it's if that patient had an MI, that is probably because there was a poor control of the other risk factors, but probably that would have been worse if they were not on an SGLT2 inhibitor, and probably they would have developed more heart failure.
The other issue is hyperkalemia is a common problem faced by us, particularly the patient has CKD, is on ARNI, is on MRAs. And what is the utility of these new potassium binders, petromer, sodium, zirconium, psychosalitaries? What is your experience? How do they help in managing these difficult scenarios of heart failure?
Look, they're very effective. We have a very good clinical, we have a clinic at St. George's where we basically there is a cardiorenal where we see patients together with a nephrologist. What is important is that we learn that we don't have to be too scared about potassium just above 5 or 5.5, but also we've learned that the potassium binders are very effective and that they should be used in all patients. So we've now routinely used the potassium binders in all patients with hyperkalemia, also because MRAs are very effective. I mean, if we look at the mortality benefit in RELS, in Ephesus, and in Emphasis, it was 35%, so which was much higher than any other drug. So we need to use the MRAs, and if we have a side effect, then for the hyperkalemia, then we need to use something. Look, it's the same thing of a patient having cancer. If they have cancer and they need to receive an anti-cancer therapy and they have nausea, then of course you give them treatment for nausea in order to continue the treatment for cancer. So the same with the potassium binders. Potassium binders, they should be used to optimize the treatment with the MRAs.
When it comes to the question of selecting between spironolactone and eplerenone in heart failure, it is said that the metabolites of spironolactone continue to be there in the blood for 4 or 5 days, as against eplerenone will disappear in 24 hours or so. So if there's a potential for hyperkalemia, is it that eplerenone should be preferred over spironolactone? What is your viewpoint?
I mean, the eplerenone also has a beneficial effect, has also the effect that gives less gynecomastia. So that is that also adds to your first question, that is how we improve the adherence. So of course, if you get gynecomastia with one drug, then you tend to stop it, and you are likely to take another of the same class. So this is why probably I would go for eplerenone.
The other issue where this worsening heart failure we are commonly facing, and Versuget is producing good results in worsening heart failure, and the side effects are virtually negligible. The issue is, can Versuget be used for prevention of worsening heart failure? So that worsening heart failure, is there any data available, or there is no such data?
Yeah, you know, the patients in the Victoria trial had both recent worsening heart failure, or they were within 6 months from an episode. So, and the effect was similar in those with worsening and in those with chronic heart failure. So there's a clear benefit of verisuatol across the board. So,
Yes, please.
so if you see that patients that is starting to tilt towards a worsening, then I would start the verisuatol.
Versuget also decreases pulmonary artery hypertension. So, is there any data if the patient of heart failure is right-sided heart failure, also pulmonary artery hypertension, also will the benefit will be more, or there is no such difference?
That is an excellent question, and of course there is a clear evidence for a greater benefit in those patients. However, we lack the data, and but there is a clear rationale for its use in those patients.
In chronic heart failure, say EMPA 10 or 25 may not better, but in acute heart failure, is it that EMPA 25 may be more beneficial? Is some data emerging on this?
I mean, it's the 25 the 25 has never been shown to be more effective in heart failure. Of course, we have a higher dose that is mostly for the treatment of diabetes, but it's I don't I think we don't have enough data, and in those with acute, what is important is a nephron blockade. That is important, the global sequential nephron blockade. And there was an important trial at the presented at the HFA that, for brevity, I didn't in my presentation, where patients with receiving furosemide were also randomized to either metolazone or dapagliflozin, and they demonstrated that the effect of dapagliflozin is similar to that of high dose of metolazone. So that basically means that when you use it as a sequential nephron blockade, it works very well.
The other difficult scenario which we face in our day-to-day practice is patient has heart failure, patient has CKD. The EGFR is 20 or less than 20 when dapagliflozin or empagliflozin is not recommended. But because the benefits of heart failure are not dependent on CKD, the patient is having worsening heart failure, will it be appropriate to use SGLT2 inhibitor in these patients of CKD where the EGFR is say stage 5 but patient has distressing heart failure, although now available is 2?
Yeah, it's a bit off label, but in patients with included in the DAPA-CKD, it was clearly shown that patients with progressive worsening of renal function, but receiving dapagliflozin, had a significantly less need for renal replacement therapy, and therefore they were less frequently underwent dialysis. What I suggest, I mean, it's just an empirical, it's not based on clinical trial. Maybe start with a lower dose, monitor the renal function, and then maybe go to the 10 milligrams later.
The guidelines recommend class 1 indications for diagnosis of iron deficiency, but when it comes to the treatment, it's 2A. Why this disparity?
Because unfortunately, both trials that were conducted in heart failure, both the Ironman and the AFFIRM, were conducted when the COVID was around. And you know that during COVID, the World Health Organization required to diagnose any patient, any death for COVID as a COVID death. So both trials, and that is the reason why the two trials, I mean, the sub-analysis of the two trials was not taken into consideration. But if we look at the COVID sensitivity analysis, so that when we look at both trials, the Ironman and AFFIRM-HF, in patients who were censored on March 3 to 2020, that is when the COVID-19 was declared as a pandemic, both trials are very significant. So I think that we should use that, but also look at what will come with the new updated guidelines that will be released very soon at the European Society of Cardiology Congress.
Do we have any important trial of iron deficiency with iron therapy in HFpEF? We have lots of trial in HFrEF.
Yeah, the AFFIRM-HF was included patients up to 50% of left ventricular ejection fraction. There is the FAIR-HFpEF that is currently ongoing, and we'll probably have the results in a year and a half.
The last two questions. The human myocyte is not endowed with an endogenous capacity for repairs. Once dead is dead forever. We have been looking at cell therapy for so many years. So what is the current stage? Is it the end of the beginning or beginning of the end? Cell therapy.
I think that at the present, there's no evidence. Probably we don't understand exactly how many cells were and how to infuse. There was a study from John Tirling who presented last year at the HFA that demonstrated that the too many or too few cells are not effective. So probably we still need to have an evidence. Probably rather than the stem cell therapy, now we have these new patches made of stem cells that can be applied surgically, and they are very promising.
We have been classifying heart failure based on ejection fraction for decades together. We know ejection fraction has limitations. You can have a normal ejection fraction and yet have subclinical systolic dysfunction as manifested by decreased GLS. So are we thinking in future that the classification of heart failure may be revised, or heart failure classification based on ejection fraction will continue to dominate the scenario in future also? Your thoughts, please.
I mean, this is an excellent question. Both the HF, we are working with our colleagues of the Heart Failure Society of America and the Japanese Heart Failure Society. So the three societies will come up soon with a consensus on this very issue. Of course, we have evidence now for drugs that work all across the left ventricular function. And so we need to change our understanding of left ventricular ejection fraction, and also we shouldn't be classifying patients into silos.
We deeply appreciate the clarity of answers and the precise answers you have given. We would have liked the session to continue on, but all of us know every wonderful thing has an end. Rather, they end much earlier than we expect. So with this, I'll hand over the mic to the organizers. Thank you very much. Thank you very much.
It's been a great pleasure being with you, and I hope to be with you in person sometime soon.
Thank you.
I must say, Professor Rosano and Professor Manoria, it's been an honor to host both of you. And from what we hear and from the feedback we get from the audience, there's been an audience which has truly loved the session. It has been an academic feast for people who have heard. And we truly thank both of you, Professor Rosano and Professor Manoria, for enriching the knowledge of all those who have joined in. We also thank you, ladies and gentlemen, from the dear audience who have joined in and have given your valuable time to ultimately take in snippets which ultimately will aid in enhancing your clinical practice and ultimately empower you to have better patient outcomes in your clinical practice. Last but not the least, we also thank our technology partners who have aided in the very smooth streaming of this webinar. Thank you, one and all. Good day.
Dr. Rosano, sometime would like to have whole 1 hour session only on questions and answers, no lectures.
I'll be delighted.
It's a pleasure to hear from you.
Be delighted.
Yeah. Thank you. Namaste. Good night.
Good night, sir. Namaste.
Thank you very much.
Namaste.
Thank you, Dr. Rosano.
Thank you.
Thank you, sir. Thank you.